Um, Good morning, everyone, on this beautiful May 1st. I am very glad to be here, and thank you also for making your time on what is considered an official holiday in many of the countries we are in. My name is Anastasia Leukhina. I will be hosting this air, and it is my pleasure to do it together with Jane Ege Møller from Aarhus University. I will briefly speak about this series and the context in which we are doing this event. Then we will hear Jane's reflections and remarks. She prepared a presentation for us, and after the presentation, you will be able to ask questions in a real life mode, and we will probably not be able to answer all of them. And we also received quite a bit of questions. Thanks to you and your filling out the registration forms. They really helped us prepare for this. So yeah, we will basically split it into two halves. First the presentation and then the Q&A. I will just really briefly introduce myself and then Jane. So I'm the author of the non-scary book about life, death, and everything in between. And then after the book came the manual for teaching empathy and humanity in healthcare. And basically, we have been doing this in the framework of the Swiss-Ukrainian project support to medical education in Ukraine. We have designed this series of workshops and discussions. In the framework, we called it um, the empathy lab. So like a person, not a diagnosis. So how do we interact with a person? And this is a series of online discussions and events with Ukrainian and also international speakers, helping us to share the best practices and the challenges and the problems in teaching healthcare communication and empathy, to discuss how we can address these challenges and share solutions, and also to support the Ukrainian medical educators and doctors in introducing communication and empathy into their programs and integrating that into their courses. So we hope this will be very practical, and we will be thrilled if you join us for some of them. We are working live, and the air is in YouTube and Facebook. And if you have any comments or questions, you can leave it under the video, and we will be able to see them in live mode. My story with Jane goes back to, I think, 5 or 6 years ago, and when I started working on this topic, basically more professionally, not just as an activist, I joined it's International Association of Communication and Healthcare that unites people from all over the world doing their work in healthcare communication or developing it. And that's how I met Jane. I have been to some of her workshops. I have really enjoyed her leadership as a co-chair of the teaching subcommittee, to which I also belong. And when I reached out to Jane with the idea of sharing her experience, I am so glad that she said yes. And basically, we wanted to start this series also with sharing international experiences, with the topic that to help all of us understand how we think we are unique with our challenges and problems, but not really. And that's why we decided to speak today about the challenges in teaching clinical communication skills in Denmark and beyond. And we hope that this will also help all of us today reflect on how they relate to the challenges in Ukraine and how we can learn from each other. Jane is an associate professor at the Department of Clinical Medicine at Aarhus University. She has a background in literature, communication, and philosophy. And she has done a lot of research, I understand mostly qualitative, on topics that are related to doctor-patient communication, doctor-doctor communication, communication skills training that she has done tons of, and narrative approaches in medical education. Um, so I think with that, I will pass the floor to you, Jane. And thank you so much for joining us today.
Well, thank you very much, Anastasia, and for that very generous presentation and introduction of me. And thank you also very much for the invitation to come and join you and the Swiss Ukrainian project. And share with you out there some of the challenges that we face in teaching. I'm really very grateful for the invitation, and I would like to start just expressing my gratitude to the organizers, Anastasia and Tanya. And also, I would like to express, my support for this kind of for you in the Ukrainian context at the moment, and I feel a bit humble, to be honest, talking to you today, because the context I work in when I teach clinical communication, I am aware that at the moment I am less challenged than what you are facing out there. So I just wanted to recognize that to begin with before we move on. But I hope that this talk, sharing my experiences, like you were saying, Sia, will be relevant in some way or another. So let's with having said that, let's move on. And like Sia was saying, I am from Denmark. I'm from a city called Aarhus, and I work at Aarhus University as an associate professor. Uh, and that's the picture of our university you see in the below below the text. I am also the academic lead for the communication skills courses for residents in Central Denmark region, and I mention that because I'll be talking a bit about them, because these are the context from the challenges that I face, and also I would like to share some of the ways that I, together with my colleagues, try to overcome them. Uh, this third thing, like you were saying, Anastasia, we know each other and have known and worked together. I have been so lucky to working together with you for years now. And as you said, I'm a part of the organization called EACH, International Association of Communication in Healthcare, and I'm the chair of the TEACH subcommittee. And I'll just share a couple of slides about TEACH and EACH, because it might be an opportunity for you as participants and audience today, linking up to EACH as an organization, because where you at the website you will find resources that might be an inspiration if you are developing teaching sessions, or also if you're conducting research in this field, or if you want to know more about policy making. So I just wanted to emphasize the organization. It's an interesting place to look at, and a lot of freely accessible resources for all teachers all over the world. So like you were saying, Anastasia, the teaching subcommittee, what we strive to do is to support and help healthcare professional clinical communication skills training in the various contexts all over the world. So enough about that. And let me just change the slide and show you what I felt together with Anastasia and Tanya would be a nice starting point. Because when we're talking about challenges, what is it actually that is the challenges that we deal with? And I'm very grateful that you responded to the survey we sent out, and the list I have made asking you what you feel are the most pressing challenges is actually based on partly the literature and the research we know exists when we talk about what challenges exist for teaching clinical communication skills. But also, of course, it's from my own personal experience. And as we move along, I hope that I'll be able to share a bit of both. However, I will be sharing more of my personal experiences, and hopefully there will be a couple of references for you to think about. What we know from the literature is that limited resources and time constraints is really often mentioned when we talk about clinical communication skills. The lack of leadership support or faculty that lacks necessary competencies is another one. Learner resistance and also feedback perceived as personal criticism is mentioned, as well as it is emphasized that there exists a gap between how we teach clinical communication in the classroom and then how it actually looks in clinical reality. We face lack of support among colleagues because they don't value communication skills as just as important as, for example, core medical or clinical skills. So let us have a look at your response to this, because I think that this whole session is about sharing challenges. And from your reporting back, you can see that all of the different challenges mentioned in the survey actually is recognized by you. But there are a couple of ones that sort of stand out. And I think if, of course, the limited resources and time constraints is absolutely crucial to all of us. And it's also repeated in literature from other parts of the world, that it is an ongoing challenge, finding the time, finding the resources. The other big one here is the gap between classroom and clinical reality. So there seems to be a recognition among us today that we do face, sort of the tricky part is to jump from the classroom setting and then to the clinical reality and make what is taught in the classroom work as lived experience in the clinical workplace. I also see that that the feedback is perceived as personal criticism is one of the ones recognized, as well as faculty lacks the necessary skills and colleagues not valuing what it is that we are trying to do when we say, well, teaching clinical communication skills is really important. So I think that's really helpful for us to think about. And as we move along, and as I move along and share some of the challenging situations we feel and how we can try to think about overcoming them. I think that this particular bit is really worthwhile doing when we think about what it is that we want to do as clinical communication teachers, because for two reasons, actually. One is that starting to do a bit of analyzing help us in identifying what problems exist, what problems we can actually do anything about, and also what is out of our scope. So that's one thing. The other thing is, like you also was addressing, Anastasia, in your introduction, that sharing the challenges is actually also something that is that has the effect that we feel less alone, less isolated, and less like it's my problem that I have this challenge. But we actually recognize that there's a common problem that we share communication skills teachers abroad. So that's, I think, there are two good things in starting with the challenge and figuring out what are they exactly. Is it something I can do about? And then the good news, I'm not alone. It's not only me. So if we have all these challenges, then why bother? I think if you have signed up for this talk, you would already have some of the answers. But what we do find is that, that it is important, communication skills and the being able to communicate in an efficient way is actually the driver of humanity and empathy in the clinical setting. So it's really important to when we speak about how we can get a more human or more empathetic uh, hospital or general practice setting or conversations in other healthcare context, then I think that the communication skills are the drivers of those things. So that's, I think, would be the place to start. It's also essential for doing effective work as a healthcare professional, and that despite, whether you are a doctor or medical students like the ones I normally would work with, or whether you are a nurse, physiotherapist, dentist, or other healthcare professionals, excuse me. So actually being effective in what you're doing also entails that you have effective communication skills. We know from the literature that communication skills is the key to patient-centered care. And we also know that enabling patient-centered care actually has very positive health outcomes, not only in terms of patient satisfaction, but also in terms of patients understanding better their treatment and also complying to them. So we both have, the soft kind of health outcomes, like patients feeling that they're being acknowledged and recognized more by their clinicians and healthcare professionals. But we also do have research supporting that there are more, hard effect measures that are where communication skills play a role. Excuse me. So, and why is that? Well, it is because it helps identify and address the patient's problems. And then lastly, I think that teaching this and being able to do it in a way that moves our learners and also creates our enthusiasm as teachers. And as what we do know is that being able to do this effectively also builds one's enthusiasm as clinician. And that is, there might be some of the research being done in Breaking Bad News, where you deliver really tough messages to the patients. We know from the literature that doctors, nurses find that this is particularly challenging. However, being able to do it in the right way creates that feeling of being able to do your job in a good way, and that creates enthusiasm about your own work. So, and then we know that sharing challenges with peers build community and support. So this is a very fantastic starting point for all of us to think about the challenges and share them more broadly. Okay. When we look at the challenges, I would like to sort of divide them into three sections. Some of them are learner related. Some of them relates to the meeting we as teachers and facilitators in these programs face when we have learner reactions at different levels. And I'll speak a bit about that, and I have prepared a couple of stories and cases that might be useful in our thinking about this. We also have challenges that are more faculty and teacher related, and I'll talk a bit about that. And then there's the more organizational challenges. What kind of programs do we have available? What kind of resources do our organizations provide? Is this recognized in, for example, the university and other educational institution as worthwhile to invest in? How do at another level, how do the national health boards view communication skills, etc.? So there are work to be done in all different fields, and all different types of challenges creates different kinds of or calls for different kinds of reflections and thinking. I have been a communication skills trainer and developed curriculum developer in various communication skills programs for more than 20 years now. And I have faced all of these challenges, and I still do. So I just wanted to mention that, this is not only I hope hopefully not only relevant for you, but it's also very relevant for me as an experienced trainer to continue this dialogue in our community of teachers, to share our challenges, because they never go away. So at least that not yet. So I think that this is something. This is only the start of a conversation that is really important to continue and having over time. So also to just come with a disclaimer, I don't have the solutions to, get rid of all the challenges, because that is not possible. But the helpful perspective is that we can actually talk about them, and we can address some of them as we move along. I just wanted to mention a couple of the frameworks, a bit of the Danish context, and a bit about the frameworks we work with, and and that's just to get us thinking about the learner-related challenges. So in Denmark, apologies for only addressing medical schools, but my working background is in the medical school in Aarhus University and in the residency training program. So my knowledge is that is what I know about. I know that for sure that there's a lot of stuff to be added about nursing and physiotherapy and other health professionals, but it's just not the part of this what I do today. But just to mention to you that in Denmark, we are fortunate enough that all 4 medical schools have communication skills as part of their curriculum. So it's recognized here, speaking in terms of the organizational level, it is recognized here that it is something that you should have in your medical schools programs. It varies how it is done from school to school. Just to give you an example, in Aarhus University, in my hometown, my home institution, the medical students have a short course during their bachelor program, and then they have a bit more training during the master's program, both including classroom teaching and also teaching during their clinical rotations. And Anastasia, I can see that you have raised your hand. Do you want to jump in at this point?
Yeah, maybe I will just ask some questions that were in the registration form along the way,
Yeah.
and one of the questions that we got is like, who should be responsible, or who is responsible for integrating communication skills into the curriculum?
Yeah, well, that's a really good question, isn't it? If I had the answer to that, I think I would be able to tell you, and you would be able to go. We will be able to solve the problem in all countries. So I think that in what works in my context, I can tell you that what works in my context, when we speak of integrating communication skills into the curriculum of the medical schools, that would be the institution, the university institution, who is responsible for integrating that. Now in Denmark, we have boards where you have participants, or you have members in the what is called the study board, which both consist of teachers, faculty members, but it also has student representatives in them. And I know from time to time that students will ask for emphasis on certain topics. And I think that it should be it is the institutional. You cannot do it on your own. You have to have some kind of institutional support. Now, where does that come from? In the second part of the Danish program, which is the courses for residents, I know that the drive to actually develop and have mandatory communication skills courses for all first-year residents in Denmark, which we have had since 2004, that came from the Danish National Health Board. But I think that so they're responsible for that. They're the ones who drives that, and they distribute it to some of the educational councils in the regions. But it's the Danish National Health Board who says we need this kind of training for our doctors. I think they were made aware that the story behind it is not something that is written down, but I know that there was quite a lot of development within the medical profession itself to say we need training in this. If we are able to fulfill the demands of the patient organizations, if we are able to fulfill the new kind of challenges we face in terms of being more efficient in the way we run the hospitals, at the same time as providing empathetic encounters, then we need as medical doctors, we need training. And of course, that was, as it always is, that was some parts of the medical profession stressing the importance of that. But it of course there was disagreements and battles about that. But so yeah, so to the pre-graduately is the universities who integrate it, and postgraduate, but that's also because the Danish postgraduate medical training is not university based. So yeah, so that's just to answer that question. And I think that it is also integrated in the way we evaluate and assess doctors in their specialist training. So it is a requirement that communication skills is a competency that is assessed. Like in Denmark, we have our training, postgraduate medical training, is structured based on the CanMeds. The 7 doctor roles, and communicator is one of them. So I think that you have to have that kind of political buy-in. You cannot base your training on the CanMeds framework without addressing the role as communicator, because that is part of that. So yeah. Just a bit about some of the models and some of the approaches that I find really helpful, and some of them that we use in the Danish setting. And I just wanted to mention the Calgary-Cambridge guide and the ALOBA model, and I'll return to those as we go along. Now, just to make sure, I'm not particularly rigid about what kind of model or what kind of structure you use when you teach communication skills. However, I do find that you do need some sort of structure and some sort of model, both in terms of helping learners, but also in helping yourself as a teacher or facilitator. So that's what the Calgary-Cambridge guide provides for us. There are other models, Spike, NURSE, 4 Habits, and I think that that you can choose whatever model you find, and I'll go a bit through the Calgary-Cambridge guide, and then I'll speak a bit about how we train and how we provide feedback using the agenda-led outcome-based analysis, because that is one of the approaches that can help us identifying or overcoming one of the challenges you identified as dominant, namely that learners sometimes experience feedback on communication skills as personal criticism. And I think that ALOBA help us. It's one of the elements of the best practices we have available in order to overcome that challenge. So I'll return to those, just briefly introduce you to them, and then we'll have a couple of cases with patient, with sort of learner reactions. Yes, Sia?
I hope I'm not interrupting you too
No,
often.
it's great.
So another question that came in the forum was that many people believe that communication is like something you are born with, and
Yeah.
empathy. that it and basically very little attention is being paid to it because people think that it cannot be trained and it's not really possible. It's like you have it or you're not. It's like a primary personal setting. um Maybe you could just address it in some way when you speak about these models. And
Sure. No, I just before we move on, I think I really recognize that position, and I would say I don't agree with it. I agree with that we people vary. So the way I communicate varies if I compare to my husband. So of course there are personal variations, and nothing, no bad things said about him. But we all, of course, we have individual and personal styles. However, we develop as human beings, and we develop our communication this whether or not we actually are aware we do it, and you can actually change the way you change it. Like my example, and I'll come back to that, is that it's not like when you have a medical student, it's not like the way that they are taught to go through a patient's story using the structure, the medical record. That's not a natural way of communicating. That's something you learn as a medical student, that first you ask for this, and then you ask for that, and then you ask. So that kind of structure is something that you learn. Now, so of course, you can learn another structure. And speaking of encounters between healthcare professionals and patients, that is a professional conversation where you actually have an aim and you have outcomes, which is different from when you and I, Anastasia, when we sit and have a cup of coffee together. It's not a professional encounter, so we can be intuitive and use the kind of personal style, but you have to switch that. And so it's just to mention that I think this is something you can learn, and we do it all the time. We just have to be conscious about what kind of structure, what kind of skills we learn and how we use them. So but yeah, so you just jump in, Anastasia, and put in all the good questions. And I really was very inspired by reading those. So thank you for providing them. If you look at, I don't know how many of you know the Calgary Cambridge Guide. If you do, this is completely basic knowledge. If you know another model, you will be able to recognize that it's the same kind of idea about breaking the professional encounter into phases or into sections, thinking about what it is that you have to do in each section. So, for example, thinking about what is important when I initiate a session, what is important when I, as a doctor, meet a patient, what do I have to do? And that would enable us to figure out, how do I do it? So if I have, as one of my goals or one of my aims in the first part of the conversation, is to identify the reasons for the consultations, both why the patient or the relatives think they're there, and also what I, as a healthcare professional, think is the reason for the consultation. Then I need some skills to get to that goal. So and I think that enables us to break down what it is that we're trying to teach, and make it concrete and make it specific, instead of being, a bit fluffy. That's one of the criticisms I hear from both medical students and residents, young doctors, junior doctors, is that communication skills often is a bit fluffy. And I think that what happens is that is when we do not go use an analytical approach, dividing it and thinking about what is it actually that we're trying to do in these clinical encounters. So just to go through it, you have 4 or 5 different phases: is initiating the session, gathering information, the physical examination. Then you have this is followed by explanation and planning, and then you have the closing of the session. And as you can see, you have different aims, you have different goals as you move along. And what the 2 arrows in the side illustrates is that continuously, while you are talking and you're trying to achieve these aims, you are providing a structure for yourself and the patient, and you are developing a relationship between yourself and the patient. And I would like to emphasize actually that both arrows, both the providing structure and the building relationship, is really helpful for not only the patient, but also the healthcare professional. Junior doctors, in my context, struggle sometimes with finding their way, and actually providing structure in the conversation actually helps them figuring out what their clinical reasoning is all about. So I think there's things are integrated in many interesting ways. So that was just a bit about the Calgary-Cambridge model. And I just wanted to highlight the teaching part of that. So where the Calgary-Cambridge part helps us to with what it is that we are trying to teach. And of course, I just wanted to go back one slide and saying, one of the things that is really key when we're talking about structure is that it's not a teaching these kind of models. It's not a tick boxing exercise. It's not the case that you have to tick off and say, I have done this, 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 and this. When you have your structure, it sets you free also to be flexible. And that is where we want to go, because people are different from each other. And my situation one day is different from what it is a year after. And I would be needing probably different things. So thinking about structure is not standardizing. The aim is not to standardize communication. It is for healthcare professionals to have a structure which can also set them free to be flexible in terms of what patient they are meeting. So then we flip to the how to teach it, and I think that one of the challenges we all face is, how do you provide feedback on something like communication skills? Because it's a bit different than some of the other medical skills that you provide feedback on, like, for example, how you do surgery, or how you decide on a medical treatment or referral. So how do you actually teach it? It's a bit slightly different skill than some of the more technical skills. Anastasia, you just jump in.
Yeah, so maybe also you could speak a bit about evaluation. Like, we have a couple of questions related. How do you assess that the student has learned or understood, and how do you evaluate empathy? And like, how do you measure progress in this kind of training that some people consider to be so fluffy?
Oh yeah, no, that's a really good question, and it's a continuous challenge. And I think that assessment is a really important part of this. And I think it's very important to distinguish. First of all, is to distinguish between two kinds on feedback. Like, for example, there are several distinctions we have to make when we talk about assessment. One thing is talking about summative and formative feedback. So if I'm at an exam, I'll be receiving summative feedback. Like, I will receive a grade. For example, you performed this kind of conversation and I give you this or that particular mark or grade. Formative feedback is not about grading. It's about providing feedback so I can evolve and I can develop. And both things are completely fine. We just have to find out what it is that we do when. So if you're doing summative feedback, I would actually like to go back to this one. If you do summative feedback, some of the rating scales that have been used is built, for example, on the Calgary-Cambridge guide. And that makes it more easy. It's never easy to assess communication skills, but it makes it more objective, or maybe intersubjective, when you assess a communication encounter. For example, a student will have with a simulated patient during an OSCE exam, for example. Then how do you rate it? Well, if you have the structure and you have the skills specified, you can actually mark. So did the student manage to establish rapport, and did he greet the patient? There's a set of skills that actually defines whether that helps finding out whether you actually establish rapport to begin with. So it has to be very skill specific, and because it also has to be transparent to the students why it is that they fail sometime. Because if it's only subjective gut feelings, then that reinforces this whole idea of communication skills just being some fluffy, subjective, blah, blah, blah. And this is not what it should be. So you really need to be very skill specific and skills oriented. You also need to be skills oriented when you provide feedback and when you try to support progress for learners, when you're doing formative feedback. And I think Aloba helps thinking about, making learners, whether they're students, whether they're trained doctors, thinking about their own, what it is that they're trying to achieve, what it is that they're struggling with, if they can reflect on how they could do differently in order to achieve what it is that they're trying to achieve. And I think that this particular framework about getting learners to identify, to begin with, what it is that they're for, uh, what it is they think that they might help them achieving whatever it is. Like, for example, I have uh, a typical learner in a general practice resident would say, I would like to keep the time, but I would also like the patient should feel recognized, and I would like to be able to find out that she has a sense that I know and I understand what her perspective is. So that calls for a specific set of skills. There's several skills we can talk about using, like, for example, asking an open-ended question to begin with, uh, uh, picking up cues about if the patient looks worried, picking it up, saying you look worried, instead of ignoring it, for example, and having that whole conversation, but basing it on what the learner is actually trying to do. That would support progress, and that would be a different way and a different approach to evaluating progress, because then it would be a question about how did you get to achieve what it was that you can actually achieve. So if you have groups, and if you're working with groups, one thing is evaluating individual learners, but if you have group sessions, this particular framework helps me in involving the group in trying to sharing what is it exactly that we can learn from this session, and how can that help me in my communication with patients and relatives. What I really like about this particular framework is that it discusses skills and not attitudes or personalities, and that's the in the bottom here. So I think there are two parts of why this is really helpful. One thing is it helps the learners thinking about communication skills as skills and not something that is part of my personality or something that is wrong with the way that I am, but something that I can actually change. So viewing it a bit like when you learn how to ski. I mean, I'm really bad at skiing, but I don't see it as a personal criticism if the ski instructor says to me, Jane, you're keeping the skis in the wrong direction. Then I'll say, okay, then I will straighten it, or I would do whatever you tell me to. And then I would see that I actually achieve moving forward, if that was what I was trying. And and I think it's a bit of the same thing with communication skills. If you can look at it as something where you're trying to do something, and we can help each other, being more specific about what kind of communication skills you need, then you don't have to feel that it's something that relates to you as a person. And I think that's really helpful. Of course, it does relate also to who we are. I am aware of that, but developing skills, that makes it easier, both for the learner, but also for the teacher. Yeah. Okay, so let's start doing a bit of work. And Sia, if you have any ideas, jump in. But we can just go, and please, if any of the participants, if any of you out there have any thoughts about these as we go along that we cannot address now, then feel free to address them when we have the Q&A session. So
Or,
one of the, yeah,
sorry, just a question quickly. Participants can also write us under the video. So if
sure.
you have some ideas or you would like to interact about it, I mean, you can
I would.
just write them out and I will voice them to Jane.
Yes, please. Please come up with all ideas, and we will see how many of them we can address as we go along. This is the fun part of sharing challenges with colleagues all over the world, is to actually get ideas. So this is a fourth year medical student. We call him Eric, and I have met that particular student quite a lot during my career, teaching in the medical school program in several universities here in Denmark. Now, I don't. When we talk about limited resources, one of the limited resources sometimes is that you do not have money, for example, to employ simulated patients who are trained. And I don't know whether that's the same thing in your context, but in some schools in Denmark, in some of the programs and in some of the courses we don't have funding for that. In other parts, we do have funding for simulated patients. So sometimes we work with the constraint that we do not have resources for that. Then what do we do? Well, we would like people to practice. We would like learners to do experiential work, but they actually try out using different kinds of skills, asking an open-ended question, seeing what difference it makes in terms of asking a closed question. So role play is one of the most frequently used methods. Sorry, just have a water. Now, this particular learner, Eric, he has a problem with role play, and he is sitting in front of his another medical student, and they do a real peer role play. Eric has the role as the patient. He's been provided what his problem is, but he has expressed to begin with that he finds role plays awkward and artificial. And then as the role play starts moving along, he breaks down laughing. He just starts laughing, and he has problems taking it seriously. And he says, "I'm really sorry, but this is just not reality." So in this particular session, what do you think as a teacher is going on with Eric? And what would you do as a facilitator? And you can just write Anastasia. If not, then and you can just have it in the back of your head while I share um, some of my ideas. So
I am
yeah.
very tempted to joke that you kick him out of class and
Yeah,
continue working with those who are not skeptical.
that's sometimes it is actually what you feel like doing, isn't it, Anastasia? That's the intuitive. You kick him out of class and then you continue with what you're doing.
But maybe in real life, I think when something like this happens, the way I take it is that it's not just happening with Eric. Other people may also feel that way or believe that way. They just not brave enough to show it. So in
Yeah.
that sense, I am super grateful to Eric that he shows it. And this is a sign as a facilitator for me that I need to slow down and I need to work with Eric and his skepticism and
Mhm.
also help others in the group who haven't shown it to
Yeah.
overcome it.
Yeah. So I like that idea, and I think that's a good alternative to kicking him out of class. Uh, the other intuitive reaction as a facilitator, which is not recommendable, would be to try to correct him. To say, well, just get into trying to get him say, take it seriously. Start taking this seriously. It's just to correct him and say, well, this is a real encounter. We build it on a real case or something. And I really appreciate what you're saying, Anastasia, because of course, what this is all about is recognizing that this is this particular learner's feeling, also exploring if you have a group. In this particular situation, there could be 15 students sitting around Eric and his colleague working together during this role play. So if you don't address these feelings and recognize them, then but try to work against them, then we often lose our learners. So instead, like you were saying, working together with Eric, thinking, exploring what his what it is particular he finds is tricky. And then the last thing I would like to say is recognizing that this is actually it is an artificial situation. It is a method that we use. It's not supposed to be reality. And my favorite example is that when doctors and medical students train, for example, intensive care, they use a lot of simulations, and they have robots, and they have blah blah blah. And when they start training that on robots in a simulation center, that's very artificial as well. But it's in order to learn some of the techniques and to work with something. So if there's a lot of things that we can get out of the equation if we recognize the feeling and explore it. Yes, Anastasia?
So I just want to add something. I think if you start fighting Eric and trying to enforce him into playing, you don't just lose Eric, you can lose the whole group. And
I
that's
would
why the situation is dangerous.
Yeah, and I agree with that. And I agree because students are also loyal to each other. And if they have just the same sense of Eric and he's being if you're working against him, then you can turn the whole group against you. So, and I think it is worthwhile, and it is difficult when we use role play and we use real peer role play. It is a very challenging, we should recognize that it's a very challenging learning method for students to engage in. It's not an easy thing to do. It would be much easier to write a reflexive text about a communication situation you found was challenging. So this is really hard to do, and recognizing that would be the way forward. It also relates to the gap between clinical reality and the classroom teaching. And I think that addressing the gap is what we have been talking about now, recognizing that it exists and what is it that we're trying to teach in the classroom setting. I would like to recommend this article, which is written by Marcy Rosenbaum, who is professor at University of Iowa, and who describes a lot of the challenges between teaching in the workplace and the workplace learning, but also address some of the opportunities. Anastasia?
Yes, and I just want to advertise that Marcy will be our guest in one of the sessions in May, and we will talk more about teaching and how to teach communication. So thank you for advertising her and strategic placement. And I also wanted to add a question that I think relates to this, like the participants. Offered to us is like, how do you teach this when students have very limited access to patients, and um, this is
Yeah.
kind of in line with the gap between reality and classroom and how to address it.
Yeah. So there, I thank you very much for that question, and yeah, I think and you are in for a treat when Marcy comes, so that's just great. Um, I and how do you? The question was how do you teach this when students have very limited access to seeing patients? So one of the answers to that is try to relate it to when they have access to patients. And I'm aware that that's, in some institutions, communication skills training is placed in the non-clinical part of the students' programs or curriculum. Um, and the challenge is to making it relevant. And one of the things I think we have to recognize is that it is less relevant the less patient contact you have. unless you have it as a high stake element in your curriculum. I know a, a lot of my colleagues in different institutions, they use simulated patients in that particular part of the program if they have the resources for them. Other things you can do is draw on students' own experiences as patients or as relatives to family members who have been in the hospital setting or the general practice. So I guess you have to deal with, I think you have to recognize that whole idea of, first of all, if you can, if it is possible to place the communication skills training as close to when the students have access to meeting patients. And if you are not able to do that, I would choose and you have resources to do work with simulated patients. I think they work to bridging the gap from the other side, because they bring in that particular bit of reality that can be so difficult for students when there's peer role play. But I think that the less experience and the less access you have as a student, you have to address it, and you have to articulate that this might not feel relevant now. But later on, this is what you need. We have a lot of students. So I have a lot of the junior doctors I work with and when I work with them, they're in the first year of their residency, and they come out and some of them are very happy about the communication skills training they had. Some of them, and a big part of them also feels it wasn't really relevant for me back then because it wasn't necessary. But now I can see it. And I know that having doctors, doing the training, addressing to medical students, for example, this is important. This is a skill that you actually need. You might not see it now, but if you start working on it now, life as a healthcare professional would be so much easier when you finish. Yes, Anastasia?
And I just want to add, as we discussed it, also the experience of Ukrainian medical educators who teach communication in the university or hospital settings. They also say that it really helps them to use either stories like from books, for example, or from our manual.
Yeah,
So
yeah,
storytelling can be a very powerful tool to help people get closer to the topic. And
yeah,
also what you mentioned, like people become really engaged when speaking about their personal stories, and it's not really that hard to do it because every single one of them was a patient, so people can really relate themselves to their own personal experiences.
yeah,
And when we speak about it, I also maybe want to put a question on the table, and please maybe you can address it a bit later, but I think
yeah.
it's very like connected to what you are saying. So somebody asks a question like, when you are doing role plays, who is playing the role of the patient? And also maybe you could share a couple of thoughts about or methodological um, recommendations in terms of how to use role plays. If you think this is too much for today, we don't have to go too far, but I just want to put it on the table.
That's very helpful. And I saw that question. I'm very happy to address it later on, because I will tell a bit about how we use role play and why we do it the way we do and what is needed to do it the way that we do. So thank you very much. I'll address it later. So I just wanted to mention another type of learner that I have met, and this is a first year resident who is in her general practice at this time. And what she expresses is that she's struggling in her general practice, in her clinical workplace. She's struggling with managing time. She's always behind, and she expresses that she can't get patients to stop talking. And she also expresses to you as a facilitator or as a trainer that she believes communication is because it's just about listening. She says it's not relevant to train because she doesn't have time enough to use the skills in the consultations. Now, this is a very common thing in my context, and from the people I've met, this is it's not only Denmark, it's all over, that I haven't the time to speak with the patient, so it's not worthwhile training. And if we think about how we can think about what's going on with ELISA here and how we can deal with it as facilitators, if you think about how you would do it, then I'll share what I would do, and we can discuss it in the Q&As later also. So my thinking about ELISA would be, again, not to correct her, saying, because one of the what she's actually telling us is that she is having problems managing times. So if we can show some of the evidence and also make her experience that communication is not all about listening and spending time exploring patients' perceptions and ideas, concerns and beliefs and whatnot, but actually it's also about managing your own time at the same time as you establish rapport with patient, then that would be a way to approach her. So what I do sometimes when residents feel that if we have video recordings and they say this took so much longer, I'll be very specific and say, so how much too long do you find that it took? Because then we can see and we can find, well, what parts where could you actually cut in? Or when is it you who is actually repeating yourself? Because a lot of the times, it's doctors have the feeling that it's the patient who talks a lot, but sometimes it's also the doctor who's talking a lot, and they could maybe skip some of that information sometimes. So that would be so. But time management is actually a really important part of communication skills training. So that would be one of my answers to ELISA. Then a third thing is Lydia, again a first-year resident, because this is who I typically meet. And after training a role play with a simulated patient on dealing with emotion, where she has been challenged throughout the role play, you should imagine a simulated patient that is really angry, and whatever she seems to do, the resident here, she seems to make the simulated patient more angry. And then we make a timeout, stopping, receiving feedback from the simulated patient and the group. And of course, and they address some of her ineffective behaviors. And then she starts crying. So what is going on with this particular learner? And what would you do as facilitators? So this is something that luckily does not happen very much in this version, but I think we do need to recognize that this particular kind of training creates emotional response and reactions in our learners. So I would definitely have to as a facilitator, I would recommend that we stop and we talk with Lydia about what is going on, how we can help her, what does she need right now, and what does she not need. So, but I think that some of the times, because we teach communication skills often we fail to recognize how strong emotions we can actually create. The last case is very, very rare in my context, but I meet this particular kind of student or resident from time to time. This is Jonathan, who aspires to be a cardiovascular surgeon, and he says he believes communication isn't his responsibility. He thinks the nurses can handle that. And he also thinks that communication skills is needed only for breaking bad news, which he doesn't think is happening in his function. So how would you respond to him as a teacher or facilitator? And I think it's very interesting to dive into what it is that explore what it is he actually feels before I would, oppose his comments. Like, for example, what is breaking bad news for you? Would be a question. And if he says, and you could give him an example. So you think as a cardiovascular surgeon that when you're amputating a foot, for example, or a leg, do you find that is a serious message? Do you find that's bad news, or do you find that is light news? And who would you, as a patient, if you were the patient, who would you like information from? Is it only the nurse, or is it always also the doctors? So I think that there are some stereotypical understandings about what kind of specialities and what kind of patient encounters actually calls for communication skills. And I think that would be, again, not opposing, but exploring what is it actually that is going on. How is it that let me hear your thoughts, Jonathan, about these particular encounters when you say breaking bad news it's not part of your work. Okay, I just wanted to highlight the feedback principles that helps me as a teacher. And there's a lot of models out there, and I think those are some of the generic feedback principles are that we should always be descriptive and behavior specific when we provide feedback. That goes back to the questions about assessment, Anastasia, because I mean, we can only observe what we can see and observe. I mean, we can only respond to what we observe. We cannot respond to people's intentions or attitudes. So we have to address those, and we have to be balance both what is working and what is not. And then just a bit of an idea for you that helps me is that I avoid labels like good or bad feedback. Good or bad communication. I use effective or ineffective because then referring back to the ALOBA, model, that will enable us to speak about what is effective in order to achieve what it is that you're trying to achieve, instead of you being good or bad. And also, as from my communication background, I would have to say that there is no such thing, to my mind, as skills that are in themselves good or bad. They're good or bad in trying to achieve something, but sometimes a close-ended questions is the right kind of question, as opposed to an open. So if we think just a bit about, so this was a bit about the learners, and I hope you recognize some of these learners and some of these issues. If we think about and talk just a bit about faculty, some of the questions that I think is important is what is needed for our faculty training? Well, first of all, training is needed. It's not something that you do just out of the blue. If you do teach this without training or awareness, at least, of what it is that you're doing, it would be sometimes it's the blind leading the blind. So we need to invest in faculty development. We need to invest in trainers. So and trying to equip them with the right set of skills, depending on what kind of methods we use. It's the same thing as role play, for example, is very difficult to do as a learner, but it's also very difficult as a facilitator and very challenging. I would recommend that you have cross-disciplinary training groups. Sometimes it's only doctors from certain specialties that teaches communication skills training. From my experience, cross-disciplinary, where you have doctors from various specialties, can actually avoid some of the stereotypical understandings of what specialties communication skills are particularly important. As one person with a communication background, I find that mixing trainer group with also people from the outside of the clinical world is very helpful, because some of the things that I can see as an outsider to the clinical workplace is helpful sometimes. And of course, there are some things I cannot see as an outsider, which is important that you have people from the inside as well. So I think that the cross-disciplinarity and mixed trainers group are important. And I think it is important to continuously invest in train and develop facilitator skills. Yeah. Organizational challenges are the most difficult, I think, because how do you work to get political buy-in? In Denmark, I know that the patient organizations have played quite an important role in addressing these issues. We have been going through a development where the medical profession has said we need training in this. But the buy-in in terms of getting the right amount of resources to this particular kind is very, very tricky. Also because it's very tricky to identify the outcomes. So you can have we had a Danish regional hospital who sent all their healthcare professionals, doctors, nurses, all on a 3-day communication skills course. And that was a huge investment for this particular regional project. It was very impressive what they did. However, it was very difficult to measure that it was actually worthwhile the investment. Anastasia.
Two questions, kind of. And please feel free to place them somewhere. One of the questions is who is training those who teach and how they build these competencies and who is paying for it? Maybe you could also share your story.
Yeah, I think if I can I'll share my story about how we do it, because I think it's a question that is very context specific, and then I'll say who pays and how we do it in my particular setting. Will that be fine? Yeah.
That would be
Good.
great.
Good. Yeah, so this is just an example from the Danish context, and this is just to give you a couple of examples of how we work with it on the courses for residents. So like I said, since 2004, all first-year residents have attended a 3-day course in communication skills. The focus is on doctor-patient communication. And in my region, the Central Denmark region, I teach approximately 300 residents per year. Like I said, in addition to that, it's a part of the specialty training, and it's also part of the workplace competency assessment. Our course is a 3-day course in total, and the way we have structured is that we have 2 modules, and then we have 3 to 4 weeks between them, and we have home assignments. And it's the Danish National Health Board who pays for those courses. So, yeah. So we have 15 residents per course. We are quite lucky not to have that many. And then we have 3 facilitators, one with a communication background and then 2 medical doctors. And they come typically from different backgrounds in terms of specialties. Some are in general practice, some are surgeons, some are internal medicine, everything, psychiatry. And we strive to have that sort of mix in the group. The doctors we meet, they have 6 to 10 months of clinical experience, and we meet them while they're doing a rotation in general practice. The content of our course is that we build on the Calgary-Cambridge Observation Guide, but we have other specific topics: talking to relatives, dealing with emotions, breaking bad news, lifestyle changes and motivational interviewing, the use of interpreters, and communicating as a young doctor, and also medically unexplained symptoms is on the agenda from time to time. So this is just to give a bit information about that. It looks like this. Module 1, we use reverse role play, where we use patients, the participants' cases. And that goes back to how you can use role play, because if you have participants with experiences, they will have faced challenges. And if they can actually bring those challenges to the workplace and work with them and find solutions to them together with their colleagues, then you have buy-in from the learner. So we do reverse role play, which means that a resident comes in with a case, and then he or she will play his or her own patient. And then another colleague will be the doctor, and we will be in groups of 5 and use feedback during a LOPA. And what is interesting about that is that some of them will have this eye-opening experience about being their own resident, being their own patient, and exploring the feelings, experiencing the feelings of what they're going through. You can only do this with people who has experience, I would say. Like you were saying, if you have learners, students who doesn't have clinical encounters, then they wouldn't have any challenges, and they wouldn't have experienced them, and they wouldn't be able to. Then it'd be more difficult to play. We also work with video recording. So between the 2 modules, they have access to digital platform where they use their telephones with patient consent to record encounters, and then they choose the one where they are most challenged, and they bring that back to the group, and then we provide them feedback. Now, this is something you can do when you're working with formative assessment and formative feedback, because if we had to grade them, we could not tell them to bring their worst. We should tell them to bring the one where they perform very well. But we find that that is the way that is valuable for us. So this is a setup where we have, and I just have to go back to this one, because we have, like I said, 3 facilitators, and they're all trained. So they have, I do the training of those, but then they also have 2 days where they're together with other trainers as observers on the course, and they provide feedback to us, and then they co-facilitate, and we provide them feedback on their facilitation. So we have first we have a 2-module course, which is 2 times 5 hours. I train the facilitators. We instruct them to perform some of we do use scenarios where they manage role play and they manage video exercises, and then they have 2 days of observation in the courses with other trainers, and we provide each other feedback before they actually start being a facilitator. A lot of the people in our group, they do a lot of courses, train the trainer courses on their own initiative. Some of them have joined teach courses, but all other courses they have where you are taught how to teach this, they do. This is paid, like I said, from the Danish National Health Board. And of course, just to finalize, this is not enough, because this is great. We really appreciate it, and the residents find that they learn a lot and it's valuable. But still, the workplace culture and the role models, despite the fact that it's changing, is a challenge. They have time constraints and working pressures. Like we were talking about, doctor's language is a particular style, and it needs translation into going into everyday language. The structure of the medical record is still what is the primarily working tool. So in sometimes in some projects, we have been working together with departments doing workplace communication skills training. And what you see here is actually a picture of the pulmonary medicine, the lung medicine department, who have been working with a project where I have trained the facilitators to facilitate video recorded sessions. And what you see in this particular picture is, in the bottom, you see a doctor who has just shown a video of a patient encounter. You see a doctor who is a facilitator, and then you see the whole group providing feedback. So, but they have these sessions every 1 hour every 8 times a year. So 8 months, once every month, they have this session. And of course, this is something that the department would have to say, yes, that is okay that you do that. So they're very lucky. Yeah. Just to give you an example of some of the research we have been doing on how we teach, and some of my research, I just wanted to highlight these particular things. And then otherwise, I would like to say thank you for the time and hear what other questions you have or comments.
Yeah, thank you, Jane. I think we managed to address quite a bit of questions along the way, and thank you so much for your flexibility. We will probably need to gradually wrap up. We still have about 12 minutes on air, and I would really love you to respond to one of the questions also from the participants. What are the biggest cultural or educational barriers you have observed when adapting approaches to teaching communication in different countries, and what do you think are the ways to overcome them? So maybe you could comment a little bit about your international work and your observations in terms of the cultural sensitivities involved, or maybe the somehow universal principles that are involved. That would be really great.
Thank you. That's a very interesting question. So in terms of the cultural barriers, I would say that if not, I think that the biggest barrier for me is not exploring cultural differences. Like, for example, if I come with, if we think about for example, nonverbal expressions, there exist differences between us. In some countries, people are having a lot of using their hands a lot. They have their facial expressions are very much more lively than in a Danish setting, for example. And I think that not recognizing those cultural differences is a barrier for teaching, because then you tend to think about or propose your own way of having this or that particular cultural communication style, being it nonverbals or being it something else, as the universal way to do it. So I think that there are some cultural differences, and one of the most fun ones was experienced was we did a course in Teach called What to Teach, and we had participants from the southern part of Europe and the northern part of Europe, and we showed them a video recorded example of a doctor in the emergency department doing a very, very good job. It was a British doctor, and everybody agreed that it was very efficient, and she was very skilled in her communication with the patient, and we did a skill spotting exercise. And then there was some sort of concern raised from the Southern European participants. These were communication skills teachers teaching in Southern Europe. And they said, well, they felt that she seemed a bit cold in her facial expression, and maybe she should have been more lively, and maybe she could have touched the patient a bit. And then the Northern European participants said, no, 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 not much, not no touch, and no more facial. And I think that was a very interesting difference. However, having said that, all agreed that her skills exploring the patient's concerns, managing time, recognizing that she has summarizing what she had heard the patient say, was very, very efficient and very helpful in terms of finding out what the patient's problem was, both in a medical but also in a patient-oriented way. So I think that there are some bits of communication that goes across countries, and then there are some differences. And I think we should explore both and recognize what we share as aims and where we differ.
And I would like to, I mean, I'm also preparing to summarize our
Yeah,
conversation. And I think what I got as one of the key messages from you is the structure, the skills, and the time management, and the goal-oriented model, like a LOBA. So structure, skills, time, and goal is pretty much universal, and then we could explore the nuances. But all of them, the structure, the skills, the goals, and the time management, can be taught and learned and improved wherever we are in our careers.
I agree. Thank you. Thank you for that summary. That's very helpful.
That was just the beginning of my summary. But yeah, I wanted to basically really emphasize on that, and I did also make a bit of notes. So I would just like to really
Yeah,
quickly navigate through our conversation. Um, I think the first point was when we started about the organizational challenges, like how important is the support at different levels, and that you cannot do it alone. There needs to be institutional support, there needs to be a political buy-in, and it basically we need to work at many different levels to make more communication in the classroom possible.
Yeah.
And that university is the lead in all of these processes, and whether top down or bottom up, we need both, and it is the university who basically owns the solutions to the questions that arise on the way. The third point is that the challenges that you have looked at and discussed are pretty much the same everywhere,
Mm.
and they are time, they are limited resources. There is a gap between classroom and reality, and lack of necessary competencies on the teacher side to teach it, and whether a rich and well-developed country or a poor and not so well-developed countries, these challenges are really the same regardless of the level of income. And we are learning together how to work with them and how to address them. Uh, the fourth point was about structure, skills, management, and aloba, and I think we already emphasized enough on this. The fifth is, I think you really help us understand better and focus on the gap between classroom and the real life communication with patients and how to bridge it. And basically, a lot of the trainings for medical educators uh, should be focused on how to make it relevant.
Mm.
Uh, and basically, you have mentioned about the simulated patients and the role plays and the use of storytelling and family stories. And also, like in your last bit, you talked about the use of videos either from the classroom setting or from the hospital setting to analyze and learn together from it. So these are different ways to bring the patient closer to the student, even when there is no access
Mm.
immediate. Um, the sixth point is, I think, also important, and we will try to address it more in our next events. Is that the communication training can create emotional response in learners that is unexpected, and that we as communication faculty or teachers, we should also be prepared well, not only with the intellectual side, but also to deal well and respond to the emotional sides that could be side effects that could come. um, and I hope also that we could explore it further in our next sessions. And last but not least, but I think it's really, really the highlight, is that the more, and I think you mentioned it so many times, I would phrase it as exploring versus opposing.
Mm.
So, and I think this exploring versus opposing is really about how critical it is for us to use facilitation and not the top down techniques, the traditional teaching techniques, because yeah, facilitation is everything in this kind of work. And I think de facto in all our work we are also teaching doctors to facilitate these conversations more than anything. And I just want to say that I think the Swiss Ukrainian project, like, that's basically the two focuses of its work over the years. This is there has been a lot of trainings and focus on developing the feedback capacities and skills, both institutionally but also individually in universities and medical schools, and also in developing facilitation and peer group learning. So I just wanted to say and also compliment the project for doing so much work in that direction. Yeah, so thank you so much for this rich conversation. I also want to mention two things. One is to talk about thanking some of the people who organized and made this possible. That's the Swiss Ukrainian project development of medical education. And I want to thank our interpreter, Halina, for your patience and also your interpretation. I want to thank Ilyas and Sergey for the technical support. Yulia and Maxim for the communication support, and Tatiana Vachnenko for everything and coordinating all of this, and also Tatiana Stepurko and Elena Ignashuk for helping us make it possible. And I want to advertise a couple of our next events that will be happening in May. And Elias is asking me, when should I put the slide with the next events? So it's now, Elias. And yeah, we will basically have 3 events in May. One will be on May 12th. We will talk about educational competencies with Ukrainian specialists and how to build them up, like the competencies of the teachers. And also on May 21st, we will have an event with Marcy, and she will go deeper into how to teach as a philosophical and practical framework, how to teach communication. And the third one will soon be advertised online, and it will be a workshop that will be for a limited group of participants that will be focused on using the time management and how to make those 15 minutes of consultation an effective way. And we will have a couple of workshops by Ukrainian specialists so that other people can see and learn how to teach it. So please stay tuned, and all the information will be available on the Facebook page and in the mailings by the project. So please stay with us, and thank you so much for coming today. Thank you again, Jane, for your time and your expertise, and we hope to see you soon.